Okay, let's unpack this. The entire world of diuretics. For those of you seeking mastery in pharmacology, this drug class, the natriuretics, is absolutely foundational.
It really is. They're among the most prescribed drugs globally. Regulators of water and salt. Essential stuff.
Right, for everything from hypertension to acute heart failure. But to really master this, we can't just think more pee. We have to go deeper into the molecular plumbing of the kidney itself.
That is precisely our mission today. We're essentially using these 5 main pharmacological classes, these drugs, as tools to map the nephron.
Okay.
By understanding where they hit site 2, site 3, site V, and the specific molecular mechanisms they disrupt, you can start to predict not just the good stuff, the therapeutic outcome, but also the inevitable, the compensatory mechanisms and the side effects that always follow. It's cause and effect, really.
And the history behind that was kind of fascinating. Lots of accidental discovery, wasn't there? It started way back with things like mercury compounds.
Yeah, the organomercurials in the 1920s. They came from observing that calomel, which contains mercury, had a diuretic effect. They worked, sort of, but they were pretty toxic.
Not ideal.
Not ideal at all. The major breakthrough, the one that really pointed towards modern diuretics, came, unexpectedly in the 1950s.
How so?
It was purely observational. Researchers noticed that some early sulfonamide antibiotics, the sulfa drugs, were causing this weird side effect.
Okay.
Mild diuresis, yes, but also metabolic acidosis. Something clicked.
Ah, the acidosis was the clue?
Exactly. That immediately pointed towards an enzyme, carbonic anhydrase, being involved. And that realization led directly to the development of the carbonic anhydrase inhibitors, or CASE inhibitors. That was really the next chapter.
And then things really took off for oral therapy with chlorothiazide in 57, right? That gave us effective kind of medium-strength options.
Absolutely. And then just a few years later, mid-60s, furosemide and ethacrenic acid arrived on the scene. They provided what we now call the high ceiling effect.
Which totally changed the game for acute fluid overload.
It did. Suddenly, rapid, massive diuresis was possible and relatively safe, much safer than the mercurials anyway. And around the same time, we saw the potassium-sparing agents come in too.
Like spironolactone.
Right, the steroid-based one, spironolactone, and also the non-steroidal ones like amiloride. Each new class allowed clinicians to target smaller, more specific pumps and channels, especially further down the nephron. That gives us the nuanced control we have today.
Okay, let's start with the heavy hitters then. The powerhouses. The high-ceiling diuretics. Furosemide is the classic prototype here.
That's the one most people know, yeah.
When we say high ceiling, what does that actually mean in terms of effect? It sounds like, more powerful.
It means exactly that. The term signifies that their maximal natriuretic effect, the maximum amount of sodium they can make you excrete, is the greatest of all the diuretic classes.
Okay.
Unlike, say, thiazides, where the effect kind of plateaus pretty quickly, with loop diuretics, the response keeps increasing as you increase the dose. Up to a point, obviously, but the ceiling is much, much higher.
So you can really push the effect.
You really can. Under maximal effective dosing, a patient might produce an astonishing 8 to 10 liters of urine in a day. It's a huge effect.
Wow, that sheer power must make them vital in emergencies. What about the timing? How fast do they work?
The timing is absolutely critical for their use. The onset is incredibly prompt. If you give it intravenously, you're looking at maybe 2 to 5 minutes.
That fast?
That fast. Orally, it's still quick, maybe 20 to 40 minutes. But the flip side is the duration is quite short, only about 3 to 6 hours.
So quick on, quick off.
Exactly. And that prompt, powerful action is why they are often the only effective class when you're dealing with severe renal failure or acute fluid congestion, like pulmonary edema. Situations where other diuretics that need good kidney function just wouldn't cut it.
Okay, let's dive into the mechanism. Site 2, the thick ascending limb of the loop of Henle, the tello. This is where the magic happens, inhibiting that Na plus GAPS and extra plus next to the 2-CLE-COT transporter. But you mentioned something interesting about how furosemide actually gets there.
Ah, yes. This is a vital pharmacokinetic point. It's not enough for the drug to just be in the blood. Furosemide gets filtered by the glomerulus, sure. But to work, it must be actively secreted into the proximal tubule.
Secreted, like pumped into the urine.
Precisely. By the organic anion transport system, the OAT system, it has to get into the tubular fluid, the filtrate, because it acts from the luminal side of the TL cell membrane.
So it doesn't work from the blood side, it has to be in the urine side of the cell.
Correct. It physically binds to the chloride binding site on that big NAME plus K plus nanese 2 EL cotransporter protein, effectively jamming the whole mechanism from the inside. from the tubule lumen.
Okay, so that means if kidney blood flow is really bad, or if that secretion pump in the proximal tubule isn't working well.
Then the drug literally can't get to its site of action in sufficient concentration. It really highlights why furosemide's efficacy is so tied to local kidney conditions, like blood flow and tubular function.
Right. And when you successfully block this transporter, which normally pulls back, what, maybe 25% of the filtered sodium, the consequences must be huge.
Oh, massive. First, you basically abolish the kidney's ability to create that corticomedullary osmotic gradient. That gradient is essential for concentrating urine.
Mm-hmm.
By knocking it out, you block both positive free water clearance, the ability to make dilute urine, and negative free water clearance, the ability to make concentrated urine. The kidney loses its flexibility.
And what's the impact on potassium? That's always a big concern with diuretics.
It's a major consequence here. Because you've blocked sodium reabsorption so effectively in the loop, a huge amount of sodium suddenly floods down to the distal tubule in the collecting duct.
Overwhelming the later segments.
Exactly. The increased flow and the sheer amount of sodium arriving there forces an exchange. The kidney tries to salvage some sodium, and it does so primarily by secreting potassium into the urine. So marked kaliuresis, significant potassium loss, is a characteristic and expected outcome with loop diuretics.
Okay, so that covers the direct tubular effects. But you mentioned furosemide is life-saving in emergencies like pulmonary edema, and sometimes the relief comes before the patient starts peeing buckets. How does that work?
This is where it gets really interesting and clinically vital. Furosemide has significant hemodynamic effects, separate from the diuresis initially.
Okay.
It causes acute changes in both kidney and systemic blood flow. Renally, you often see a transient increase in total renal blood flow, and it gets redistributed a bit within the kidney. GFR usually stays about the same, though.
And this is driven by...
Prostaglandins.
Yeah.
Locally produced prostaglandins. They seem to mediate these immediate vascular changes.
So prostaglandins are key for the immediate effect, and systemically.
Systemically, and this is crucial for heart failure, intravenous furosemide causes a prompt increase in systemic venous capacitance. Essentially, it makes the veins relax and hold more blood.
Like a vasodilator.
Exactly. This reduces the amount of blood returning to the heart, decreasing the left ventricular filling pressure, or preload. And this happens within minutes. Before the significant increase in urine output, the diuretic effect is even apparent.
So it takes the pressure off the struggling heart almost immediately, even before the fluid volume starts dropping significantly.
Precisely. That's why IV furosemide gives such rapid relief in acute left ventricular failure and pulmonary edema. It acts as a vasodilator first, then a diuretic.
But the body doesn't just sit there and take it, right? There must be pushback, compensatory mechanisms.
Absolutely. The body's incredibly smart at sensing changes. The kidney, specifically the macula densa cells near the glomerulus, senses the reduced sodium chloride delivery caused by the loop diuretic.
And panics.
It interprets it as low blood pressure or low volume, so it triggers a marked release of renin. And renin, of course, kicks off the whole renin-angiotensin-aldosterone system, the RAAS.
The RAAS, the body's big fluid retention system?
Exactly. This RAAS activation is the major compensatory mechanism. And because furosemide itself has a pretty short half-life, maybe only 1 to 2 hours, this powerful RAAS activation can actually limit the total amount of sodium you lose over 24 hours, especially with just once daily dosing. The body starts fighting back almost immediately to retain salt and water.
Fascinating. Okay, let's talk about ions other than sodium and potassium. Divalent cations like calcium and magnesium, this is a key difference between loops and other classes, isn't it?
It's a huge point of contrast, especially with thiazides. Furosemide significantly increases the excretion of both calcium and magnesium. It makes you lose them.
Why? What's the mechanism there?
It goes back to that thick ascending limb. Normally, the reabsorption of NaCl there creates a small positive electrical charge in the tubule lumen relative to the blood side.
Okay.
This positive potential difference is what drives the passive reabsorption of positively charged ions like calcium and magnesium between the cells, pericellularly.
Right. Opposites attract, or rather, like, charges repel. Wait, no. The positive lumen pushes the positive ions out?
Precisely. When furosemide blocks the NaCl reabsorption, it abolishes this lumen-positive potential. Without that electrical driving force, calcium and magnesium just don't get reabsorbed as efficiently and are lost in the urine.
So loop diuretics are calcium wasting. Chronic use could lead to problems like low calcium levels, hypokalemia.
Potentially, yes. It's something to monitor with long-term high-dose use.
What about their metabolic profile otherwise? Things like uric acid or blood sugar?
They do tend to raise blood uric acid, causing hyperuricemia. It's mainly because they compete with uric acid for secretion by that same organic acid transporter in the proximal tubule we talked about earlier.
Okay.
It's usually less pronounced than with thiazides, but it can still precipitate gout in susceptible individuals. A small rise in blood sugar is also possible, often related more to the volume depletion and electrolyte shifts, but again, typically less of an issue than with thiazides.
Now, furosemide is the prototype, but there are others in this class, the congeners. You mentioned furosemide's oral absorption isn't always great.
Right, its oral bioavailability is only around 60% on average.
Ah,
And crucially, in patients with severe congestive heart failure, who often have edema or swelling in their gut wall,
uh-huh.
that absorption can be markedly reduced, making the oral drug much less effective just when you need it most.
That's a problem. So, are there alternatives that get around that?
Yes, and bumetanide is a key one. Pharmacologically, it's about 40 times more potent than furosemide, milligram for milligram.
Wow, 40 times.
And importantly, it's more lipid-soluble. This translates to much better and more reliable oral bioavailability, typically 80 to 100%.
Yeah.
And crucially, its absorption isn't significantly affected by that bowel edema in heart failure.
So, for oral use in someone with severe CHF and likely absorption issues, bumetanide might be preferred.
Often, yes. It's a more predictable option in that scenario.
And there's also torsemide, or torsemide. Did that offer a different advantage?
Torsemide is maybe 2 to 3 times more potent than furosemide. Its absorption is also generally good and reliable. Its main distinguishing feature is its longer duration of action.
Longer than furosemide's 3 to 6 hours.
Yes. Its elimination half-life is around 3.5 hours, giving it a duration of action closer to 4 to 8 hours. So for patients who might benefit from slightly less frequent dosing but still need that high sealing power, torsemide provides that intermediate option.
Okay, let's move our pharmacological map further down the nephron. We leave the loop and arrive at the distal tubule, the DT. And here we find the thiazides, often called the medium efficacy diuretics. Hydrochlorothiazide is probably the most common name people know.
Definitely. They are absolute workhorses, especially in treating hypertension, the gold standard for many years.
So their main site of action is site thir, the early part of the distal tubule. What's the mechanism here? Is it the same transporter as the loops?
No, different mechanism, different transporter. Thiazides specifically inhibit the Na plus NaCl symport or cotransporter located on the luminal membrane of the early DT cells.
Sodium and chloride together.
Right. And just like the loops, they don't work from the blood side. They also need to be actively secreted into the proximal tubule fluid via those organic acid pathways to reach site third and do their job from the inside.
Okay, so secretion is still key. Now, why are they classified as medium efficacy? You hear loops are high, these are medium. They max out around, 8% sodium excretion compared to the loop's 25%. Why the big difference?
It's simple geography, really. Think about the journey of the filtrate. By the time it reaches the early distal tubule, the proximal tubule and the loop of Henle have already done the vast majority of the work. They've reabsorbed roughly 90% of the sodium that was initially filtered.
Wow, 90% is already gone.
Exactly. So the thiazides are targeting a much smaller remaining pool of sodium. There's just less sodium available for them to block the reabsorption of. That's why their maximum effect is inherently lower.
And that also explains their dose response curve, right?
Oh, yeah.
It's quite flat, very flat. Once you reach a certain dose, say equivalent to about 100 milligrams of hydrochlorothiazide, you've pretty much maximally inhibited that NaCl symporter. Giving more drug doesn't produce significantly more diuresis. The ceiling is much lower and reached much earlier than with loops.
How does this action in the DT affect the kidney's ability to handle water, the free water clearance we discussed?
It affects it differently than loops. Thiazides reduce positive free water clearance,
You meaning?
meaning they impair the kidney's ability to make maximally dilute urine. Normally, the DT reabsorbs salt without water, diluting the fluid. Thiazides block some of that salt reabsorption, so the fluid doesn't get quite as dilute.
Okay, but what about concentrating urine? Negative free water clearance.
They generally do not affect negative free water clearance. The kidney can still concentrate urine effectively in the presence of ADH, even with a thiazide on board. This specific pattern helps pinpoint their action to that early DT segment.
Now, a really critical clinical point, the failure point of thiazides. Why are they generally ineffective when kidney function gets poor, unlike loops? This is a major limitation. Thiazides themselves can actually tend to reduce the glomerular filtration rate, the GFR, partly due to the volume loss they cause and maybe some direct kidney effects.
Okay.
But more importantly, if the patient's GFR is already low, typically below about 30 milliliters, two things happen. One, less drug gets secreted into the tubule to reach site 3. Two, less sodium is being delivered to the DT in the first place.
So not enough drug and not enough target sodium.
Exactly. The net result is they just don't produce a clinically meaningful diuretic effect in patients with significant chronic kidney disease. Loops, acting earlier and having those prostaglandin-mediated blood flow effects, can often still work even with low GFR.
Yep. Okay, now here's where it gets really interesting for me. The calcium handling. We established loops waste calcium. Thiazides do the complete opposite, right?
They absolutely do. This is one of their most unique and valuable properties.
Yeah.
Thiazides decrease the amount of calcium, TPOXI2 plus 1000 ATA2, excreted in the urine. They help the body hold on to calcium.
But what's the mechanism for saving calcium?
It's a direct effect in the distal tubule, though the exact steps are complex. Essentially, by blocking the NOM plus NICE cilimetry on the luminal side, it indirectly leads to increased activity of a sodium-calcium exchanger on the basolateral membrane, the blood side.
Okay.
This exchanger pumps calcium out of the cell into the blood in exchange for sodium coming in. By enhancing this process, thiazides promote overall calcium reabsorption from the filtrate back into the body.
Which makes them useful for specific conditions.
Immensely useful. They are a first-line treatment for hypercalciuria conditions where people excrete too much calcium in their urine and are used to prevent the recurrence of calcium-containing kidney stones. Plus, this calcium-sparing effect might help preserve bone density over the long term.
Fascinating contrast to the loops. Okay, what about the metabolic downsides? We touched on loops causing hyperuricemia. Are thiazides better or worse?
Generally worse, unfortunately. They cause a more significant reduction in urate excretion compared to furosemide. So the risk of hyperuricemia and potentially precipitating a gout attack is considered higher with thiazides.
And blood sugar and lipids.
Also more of a concern traditionally. Chronic thiazide use, especially at higher doses, has been linked to elevations in blood sugar, partly by impairing insulin release, an effect sometimes linked to the hypokalemia they can cause, and also potential adverse effects on lipid profiles, like raising cholesterol and triglycerides.
So, more metabolic baggage than loops, generally speaking.
Generally, yes. Although it's important to stress that with the lower doses commonly used for hypertension today, these metabolic effects are often minimal or clinically insignificant for many patients. But the potential is there.
Pharmacokinetically, you mentioned they're all pretty well absorbed orally, which was a big advantage. But their duration of action varies a lot.
Hugely. Some thiazides last only 6-12 hours, while others can last for a day or even 2. It really depends on the specific drug.
What determines that long duration for some of them?
It mainly comes down to how lipid-soluble they are and how much they bind to proteins or enzymes. The more lipid-soluble ones tend to be reabsorbed more passively back into the body from the kidney tubules, prolonging their presence. Some also bind quite avidly to carbonic anhydrase within red blood cells, creating a kind of drug reservoir.
Speaking of long-acting, chlorthalidone is one that stands out, right? It's often preferred in hypertension trials.
Exactly. Chlorthalidone is known for its particularly long duration of action. Its half-life is around 40 to 50 hours.
Wow, nearly 2 days.
Yeah, which means it provides very smooth, 24-hour blood pressure control with once-daily dosing. That's why it's often featured prominently in major hypertension guidelines and studies, used almost exclusively as an antihypertensive rather than for acute diuresis.
Then there's midazolam. It seems to have a special niche, particularly regarding kidney failure and being used with loop diuretics.
Midazolam is quite unique among the thiazide-like diuretics. First, unlike most other thiazides, it often retains its ability to produce a useful diuretic response even when the GFR is quite low, perhaps down to around 15 millimint. That puts it closer to the loops in that regard.
That's a key difference.
It is. Plus, it seems to have an additional site of action, possibly inhibiting phosphate reabsorption in the proximal tubule to some extent. But its most famous use is in combination therapy.
With furosemide.
Yes. When patients become resistant to high doses of loop diuretics, adding midazolam can often produce a profound, synergistic diuresis. It seems particularly effective at overcoming the resistance that develops due to changes in the distal nephron, a point we'll come back to.
Okay, a powerful tool for resistance. Lastly, indapamide. Another one often favored in hypertension guidelines, like NICE in the UK, but you said it has very little diuretic effect at standard doses.
That's right. Indapamide is highly lipid-soluble and gets extensively metabolized by the liver. Only a very small amount of the active drug actually reaches the kidney tubule fluid.
So not much diuretic action. Why is it a good antihypertensive then?
Because it seems to have significant extrarenal effects, direct vascular actions. It appears to relax blood vessels, smooth muscle, and reduce peripheral vascular resistance through mechanisms perhaps independent of significant diuresis. This allows it to lower blood pressure effectively, often with fewer of the electrolyte disturbances, like hypokalemia, seen with more potent diuretic thiazides.
Okay, let's move into some more specialized categories now. First up, the carbonic anhydrase inhibitors, with acetazolamide being the main example. We mentioned their discovery sort of kicked off the modern diuretic era, but you said their diuretic use today is very limited. Why? Let's start with the mechanism in the proximal tubule.
Right, so acetazolamide works by inhibiting the enzyme carbonic anhydrase, or CASE, inside the cells of the proximal tubule. This enzyme is crucial.
What does it do normally?
It speeds up the reaction between carbon dioxide and water to form carbonic acid, text stage 2CO3D3. This acid then quickly dissociates into a hydrogen ion and a bicarbonate ion, text stage TO3.
Okay.
That hydrogen ion, the text TD3, is really important because the cell pumps it out into the tubule lumen in exchange for sodium coming to the cell. It's the text TTH plus Teddy-Checky Porter.
So sodium reabsorption depends on having enough hydrogen ions to trade.
Exactly. And those hydrogen ions ultimately come from that carbonic anhydrase reaction. So acetazolamide blocks CASE, meaning less text-to-a-tinctures is generated inside the cell.
Less text plus non means less fuel for the text H plus textanger.
Precisely. This significantly slows down sodium reabsorption. And because bicarbonate reabsorption is also closely linked to this process, you end up inhibiting the reabsorption of sodium bicarbonate, primarily.
Leading to loss of sodium and bicarb in the urine.
Correct. Which makes the urine alkaline, and alkaline diuresis. But, and this is the crucial part, this effect is inherently self-limiting.
Ah, right. You said it stops working after a few days. Why is that? This is key to why they've failed as long-term diuretics.
Because by causing the body to lose large amounts of bicarbonate, acetazolamide eventually depletes the body's bicarbonate stores. This leads to a state of metabolic acidosis.
The body becomes acidic.
Yes, and once the body is acidotic, the amount of bicarbonate being filtered by the glomerulus, the very substance that acetazolamide needs to work on, drops significantly.
Less substrate for the drug to act on.
Exactly. Less filtered bicarbonate means less inhibition is possible, and the diuretic effect basically fizzles out. That's why the maximum sodium loss you can achieve is only about 5%. It shuts itself off.
And the electrolyte cost for even that mild diuresis is pretty high, particularly for potassium.
It is remarkably high. For the amount of sodium loss they cause, CASE inhibitors induce the most significant potassium loss, the most marked kaliresis of any diuretic class.
Why so much K plus loss?
It's partly because the acidosis and the altered ion handling interfere with normal distal mechanisms. With less TEX plus available for secretion distally, any remaining sodium exchange tends to happen predominantly with TEX plus dollar, leading to disproportionate potassium wastage in that alkaline urine.
So weak, self-limiting diuresis and lots of potassium loss. It's easy to see why they aren't used primarily as diuretics anymore. So why is acetazolamide still an important drug?
Because its current uses are almost entirely non-diuretic. They rely on inhibiting carbonic anhydrase in other parts of the body.
Ah, okay. Like where?
The most prominent example is glaucoma. Acetazolamide is very effective at lowering pressure inside the eye.
How does it do that?
The fluid inside the eye, the aqueous humor, is naturally rich in bicarbonate. Its formation depends on carbonic anhydrase in the ciliary body. By inhibiting CASE there, acetazolamide reduces the rate of aqueous humor production, thus lowering intraocular pressure.
Clever. What other uses?
It's very useful for preventing and treating acute mountain sickness.
Really? How does that work?
It seems to work by altering text CO2 transport and possibly decreasing the formation of cerebrospinal fluid, CSF. By causing a mild metabolic acidosis, it also stimulates breathing, which helps acclimatization to high altitude.
Interesting. Any other uses?
It can be used sometimes as an add-on therapy for certain types of epilepsy, particularly absent seizures, and occasionally to deliberately make the urine alkaline, for instance, to help excrete certain drugs in an overdose situation.
Okay. What about major side effects or contraindications? You mentioned liver disease.
Yes. Besides the expected metabolic acidosis and hypokalemia, a critical contraindication is severe liver disease, like cirrhosis.
Why is that?
Because the drug causes alkaline urine. Normally, the kidney helps eliminate ammonia, the actually trapping it as ammonium, text NH4 plus dollars in acidic urine. If the urine is alkaline, this trapping mechanism fails.
So ammonia builds up.
Ammonia can build up in the blood because it's not being efficiently excreted by the kidneys. In someone with a failing liver, which normally detoxifies ammonia, this extra load can precipitate or worsen hepatic encephalopathy or coma. Very dangerous.
Definitely one to avoid in liver patients. Okay, let's switch gears completely now to the osmotic diuretics. Mannitol is the main one here. These seem totally different, pharmacologically inert.
Totally different class, yes.
Yeah.
Mannitol isn't really a drug in the traditional sense. It's a low molecular weight sugar alcohol, pharmacologically inert, meaning it doesn't interact with receptors or enzymes.
So how does it cause diuresis?
It works purely by physics, by osmosis.
Yeah.
It's freely filtered at the glomerulus, but importantly, it undergoes very limited reabsorption back into the body from the kidney tubules.
So it gets trapped in the tubule fluid.
Exactly. When you infuse a large amount of mannitol intravenously, it significantly increases the osmolarity and the concentration of solutes in the tubular fluid.
And water follows solutes.
Water follows solutes. This high concentration of mannitol literally holds water isoosmotically within the tubulumen, particularly in the proximal tubule, and the descending limb of the loop of Henle, which are very permeable to water. It prevents water from being reabsorbed.
Does it do anything else?
Yes, a couple of important things. Because it increases the osmolarity of the blood initially, it actually draws water out of body cells, including brain cells, into the extracellular fluid, ECF. So it expands the ECF volume.
Pulls water from inside cells to outside.
Right. And within the kidney, the increased flow and altered osmolarity tend to dissipate that corticomedullary osmotic gradient we talked about earlier, further impairing the kidney's ability to concentrate urine.
Now, you stress this is never used for typical edema, like in heart failure or chronic conditions. Why not?
Because its primary effect isn't really sodium excretion, it's water excretion. And importantly, that initial effect of pulling water into the bloodstream and expanding the ECF volume is exactly what you don't want in someone who's already volume overloaded, like in heart failure.
Okay, so not for chronic edema. What are its main uses then? It sounds like it's for high-pressure situations.
Precisely. Its utility is almost exclusively for rapidly reducing pathologically high pressure in confined compartments. The classic uses are for increased intracranial pressure, ICP, say after a head injury or stroke, or increased intraocular pressure, IOP, like an acute angle closure glaucoma.
How does it lower brain pressure?
By that osmotic effect, it makes the blood hypertonic relative to the brain tissue and cerebrospinal fluid. This pulls water osmotically out of the brain cells and CSF across the blood-brain barrier, shrinking the brain volume slightly and reducing the pressure within the skull. Same principle applies in the eye.
Very clever. Any other uses?
It's sometimes used in cases of impending acute renal failure, particularly around surgery, like cardiac surgery, the idea being to maintain urine flow and maybe flush out debris, though honestly, the evidence for long-term benefit in preventing established renal failure is pretty weak.
Given that it expands plasma volume initially, there must be major risks if used incorrectly.
Huge risks. Because it pulls water into the circulation before the diuresis kicks in, mannitol is absolutely contraindicated if acute renal failure is already established and the patient isn't making urine, or in anyone with active pulmonary edema or severe congestive heart failure.
Why?
Because that sudden large expansion of the plasma volume can instantly overwhelm the heart, acutely worsening heart failure or flooding the lungs. It can be catastrophic if used in the wrong patient.
All right, let's navigate to the final segments of our nephron map. The late distal tubule and the collecting duct. This is Site V. Here we find the potassium-sparing diuretics. Their main job, as the name implies, is usually to counteract the potassium loss caused by the loops and thiazides we already discussed.
That's their primary role, yes. They are relatively weak diuretics on their own in terms of sodium excretion, but crucial for managing potassium balance.
And this class is actually split into two distinct groups with fundamentally different mechanisms, right? Let's start with the first group, the aldosterone antagonists. Spironolactone is the classic one here.
Right. Spironolactone is structurally similar to the natural steroid hormone aldosterone. It works by competitively blocking aldosterone from binding to its receptor.
Where is this receptor?
It's an intracellular receptor, the mineralocorticoid receptor, or MR, located inside the principal cells of the late distal tubule and collecting duct.
Okay, so aldosterone normally goes into the cell, binds the MR, then what happens?
That hormone receptor complex then moves into the cell nucleus and switches on certain genes. This leads to the synthesis of new proteins, called aldosterone-induced proteins, or AIPs.
AIPs, what do they do?
These AIPs are the business end of aldosterone's action. They do a couple of key things. They increase the number and activity of sodium channels, called ENaC, on the luminal membrane, allowing more sodium to enter the cell from the tubule fluid. They also boost the activity of potassium channels on that same membrane, promoting potassium secretion out into the urine. And they stimulate the Na plus K plus pump on the blood side.
So the net effect of normal aldosterone action is reabsorb sodium, secrete potassium, and hydrogen ions.
Exactly. Save sodium, waste potassium and acid.
So spironolactone, being an antagonist, binds to that MR instead of aldosterone and stops the AIPs from being made.
Correct. It prevents aldosterone from initiating that whole gene transcription process. No AIPs means fewer active sodium channels, less sodium reabsorption, and importantly, less potassium and hydrogen ion secretion.
Because it involves blocking protein synthesis, its onset must be quite slow, right? It can't work instantly.
That's a crucial clinical point. Unlike diuretics that directly block a channel or transporter, spironolactone's effect depends on stopping gene expression and waiting for existing AIPs to degrade. This means its onset of action is delayed. It can take several days to reach its maximum effect.
And you said it's a weak diuretic?
Very weak in terms of sodium excretion, maybe causing only 2–3% maximal sodium loss. Its real value isn't primarily as a diuretic, but in two specific situations.
Which are?
1, counteracting the potassium loss caused by loop or thiazide diuretics. 2, combating diuretic resistance in conditions where aldosterone levels are abnormally high.
Secondary hyperaldosteronism. You see that in things like severe heart failure or liver cirrhosis, right?
Exactly. In those conditions, the body is often chronically activating the RAAS system, leading to very high aldosterone levels. This high aldosterone drives potassium loss and makes the kidneys resistant to other diuretics. Spironolactone is unique in that it directly targets and reverses this aldosterone-driven component.
Okay. What about its pharmacokinetics? Does it get metabolized?
Yes, spironolactone itself is extensively metabolized in the liver. One of its major active metabolites is canrenone. Canrenone actually accounts for a significant portion of the drug's overall activity and has a reasonably long half-life, around 18 hours or so, contributing to the sustained effect.
Now, because it's a steroid molecule, structurally related to aldosterone and other sex hormones, does it have hormonal side effects?
Unfortunately, yes. This is its major drawback. Spironolactone isn't perfectly selective for the mineralocorticoid receptor. It can also interact with the androgen and progesterone receptors elsewhere in the body, leading to predictable steroidal side effects. In men, painful breast enlargement, gynecomastia, is common, along with decreased libido or erectile dysfunction. In women, it can cause menstrual irregularities, breast tenderness, or hirsutism. These can be quite bothersome and limit its long-term use for some patients.
Which naturally brings us to eplerenone. Was this designed to avoid those hormonal issues?
Precisely. Eplerenone was developed specifically to be a more selective mineralocorticoid receptor antagonist. It has much lower affinity for those androgen and progesterone receptors compared to spironolactone.
So same beneficial anti-aldosterone effect in the kidney, but fewer side effects elsewhere.
Exactly. For conditions requiring long-term MRR blockade, like improving survival and reducing cardiac fibrosis after a heart attack or in chronic heart failure, eplerenone offers that crucial benefit with significantly fewer hormonal side effects, making it much better tolerated for many patients. It's really seen now as much as a cardiac drug as a diuretic.
Okay, that covers the aldosterone antagonists. Now for the second subclass of potassium-sparing diuretics, the direct renal epithelial Na plus channel inhibitors. Amiloride and triamterene are the key drugs here. How are they different?
Fundamentally different mechanism. These are not steroids. They are organic bases, and they work completely independently of aldosterone.
Okay.
They act directly on the luminal membrane of those same late DT and collecting duct cells, but instead of blocking the receptor inside the cell, they physically block the sodium channel, ENC, from the outside, from the tubule fluid.
So they just plug the channel that sodium normally flows through?
Essentially, yes. They directly inhibit sodium entry into the cell through enants.
Okay, blocking sodium entry makes sense for diuresis, although you said it's weak. But how does blocking sodium entry lead to potassium being spared? That seems less obvious than blocking aldosterone.
It's a really elegant mechanism, actually, based on electrical potential. Think about what happens normally when positive sodium ions plus NAN rush into the cell through ENAS. That influx of positive charge makes the inside of the cell slightly less negative, and correspondingly, it makes the tubule lumen slightly more negative relative to the blood side. There's a small electrical voltage across the epithelium, the transepithelial potential difference typically around -15 millivolts, lumen negative.
Right, the lumen is negatively charged compared to the blood.
Yes,
Yeah.
and this negative charge in the lumen is the primary driving force that pulls positively charged potassium ions
Right.
and hydrogen ions out of the cell and into the urine.
Ah, I see. So the sodium entry creates the electrical gradient that drives potassium loss.
Exactly. And when loop and thiazide diuretics deliver more sodium to this segment, they enhance ENAC activity, make the lumen even more negative, and thus worsen potassium loss.
So amiloride and triamterene, by blocking ENAC,
They reduce that sodium entry. This makes the lumen less negative. By reducing that electrical driving force, they indirectly inhibit the secretion of potassium and hydrogen ions. Both K+ and H+ are spared.
clever. So they conserve potassium and potentially cause a bit of acidosis because H+ is also conserved, and the sodium loss is still minor.
Still minor, around that 2–3% mark again. Their main clinical value is definitely potassium conservation.
And are they typically used alone?
Almost never. They're used almost exclusively in combination products, usually fixed-dose combinations with hydrochlorothiazide or sometimes furosemide.
Why the combo?
The goal is twofold. Primarily, to prevent or treat the hypokalemia caused by the more potent thiazide or loop component, and secondarily, to provide a slight additive effect on overall sodium excretion. It's a much more convenient way to manage potassium than telling patients to take separate potassium pills.
Makes sense. Does amiloride have any other specific uses related to that ENAC channel?
Yes, one quite specific and important niche use. It's used to treat lithium-induced nephrogenic diabetes insipidus.
How does that work? Lithium isn't sodium.
No, but lithium ions, TEC+1, are chemically similar enough to sodium ions that they can actually enter the collecting duct cells through that same ENAC channel.
Ugh, mistaken identity.
Pretty much. And once inside the cell, lithium interferes with the cell's response to ADH, antidiuretic hormone, causing the kidney to lose its ability to concentrate urine, leading to profound water loss diabetes insipidus.
So amiloride blocks the doorway.
Exactly. By blocking ENAC, amiloride prevents lithium from getting into the collecting duct cells in the first place, thereby mitigating or preventing lithium's toxic effect on water handling.
Okay, for this final segment, let's really synthesize the risks and the clinical strategies. Because, when you're dealing with drugs that fundamentally mess with fluid and electrolyte balance, understanding the potential complications is just as critical as understanding the benefits. What's the biggest, most common problem we need to watch out for?
Without a doubt, it's hypokalemia, low potassium levels. This is probably the single most significant clinical problem associated with the high, medium efficacy diuretics, the loops, and thiazides.
Which ones cause it more?
It tends to be more common or sustained with the longer-acting thiazides, just because their effect lasts longer through the day. But any period of brisk diuresis, especially with loops, can drop potassium quickly.
And why is low potassium so dangerous?
The major risk is cardiac arrhythmias. Low potassium makes the heart muscle more excitable and prone to dangerous rhythms. This is especially risky in patients who are already vulnerable, like those taking digoxin.
Ah, the digoxin interaction.
Yes, hypokalemia significantly enhances digoxin toxicity. It also increases the risk of a specific type of dangerous ventricular tachycardia called torsades de pointe, if the patient is also taking other drugs known to prolong the QT interval on the ECG.
So how do clinicians manage this? Is just telling people to eat more bananas enough? Or potassium supplements?
Prevention is really key and often more effective than just chasing low levels with supplements. While potassium chloride supplements are certainly used, they can be inconvenient, taste bad, and sometimes cause gut irritation. A more convenient and physiologically sound strategy is often the concurrent use of one of those potassium-sparing diuretics we just discussed, adding amiloride or spironolactoneplerenone to the loop or thiazide. They directly counteract the distal potassium wasting mechanism.
So combination therapy is often the best approach for prevention.
Often, yes. And interestingly, adding drugs that block the RAAS system, like AC inhibitors or ARBs, also helps prevent hypokalemia when used with thiazides, because they lower aldosterone levels, reducing that drive for potassium secretion.
Good point. Beyond potassium, what about just losing too much salt and water overall, volume depletion?
That's the other major risk, especially with overzealous use of the powerful loop diuretics. It can easily cause acute saline depletion.
Leading to
dehydration, low blood pressure, hypotension, dizziness, especially when standing up, orthostatic hypotension. And because you're losing isotonic fluid, the sodium concentration might look normal initially, but the blood gets thicker, more concentrated.
hemoconcentration.
Right, which increases blood viscosity and actually raises the risk of developing blood clots, like deep vein thrombosis. DVT. Not good. We also have to watch for dilutional hyponatremia.
Low sodium, but dilute. How does that happen?
This can occur especially in severe heart failure patients undergoing vigorous diuresis. The potent diuretic causes salt loss, but the underlying disease state and sometimes ADH release makes the kidney hang on to water inappropriately. So you lose salt, retain water, and effectively dilute the sodium concentration in the body's fluids. Patients might even feel thirsty despite being fluid overloaded.
Tricky situation. Okay, let's quickly recap some of the other unique risks tied to specific classes. Metabolic issues.
Yep. Hyperuricemia, high uric acid, more common or severe with thiazides than lupus, potentially triggering gout. Hyperglycemia and dyslipidemia effects on blood sugar and fats, again, more traditionally associated with thiazides, especially older, higher doses, but minimal with low-dose therapy usually.
And the calcium difference is crucial.
Absolutely. Remember, lupus. Lose calcium, risk of hypokalemia long-term. Thiazides, it save calcium, can cause hyperkalemia, used for stones. That's a key distinction.
Any other specific organ toxicities?
Ototoxicity, hearing loss, or ringing in the ears. This is pretty much unique to the high-ceiling loop diuretics, especially if given too rapidly IV or in patients with underlying kidney failure. The risk is low but serious when it happens.
And the liver warning again?
Yes, the risk of aggravating hepatic coma in patients with cirrhosis. This is mainly driven by the hypokalemia and the metabolic alkalosis that diuretics, especially lupus and thiazides, can cause. Both factors increase blood ammonia levels, which is toxic to the brain and liver failure. Spironolactone is often preferred or added early in these patients.
Okay, let's talk interactions. Obviously, diuretics boost the effect of other blood pressure meds, which is often intentional, but what are the dangerous interactions to avoid?
Hypokalemia is the hub for many dangers. We mentioned digoxin toxicity and the increased risk with QT prolonging drugs. For loop diuretics specifically, you have to be very careful with NSAIDs.
Non-steroidal anti-inflammatories, like ibuprofen or naproxen.
Exactly. Drugs like indomethacin, ibuprofen, etc. can significantly diminish the diuretic and antihypertensive effect of loop diuretics.
Why?
Because, as we discussed, a part of furosemide's action, especially its effect on renal blood flow and its initial vinovulating effect, relies on stimulating local prostaglandin synthesis. NSAIDs work by inhibiting prostaglandin synthesis, so they directly counteract a key part of the loop diuretics mechanism.
So taking an NSAI can effectively blunt the effect of your furosemide.
It definitely can, especially the hemodynamic components. Less so for thiazides, whose action is less dependent on prostaglandins.
Are there interactions at the secretion level too, getting the drug into the tubule?
Yes. Remember how lupus and thiazides need to be secreted by that organic anion transporter in the proximal tubule? Well, other drugs that use the same transporter can compete. The classic example is probenecid, a gout medication. Probenecid strongly inhibits the secretion of lupus and thiazides, meaning less drug gets into the tubule fluid to reach site 2 or site 3, significantly blunting their diuretic effect.
Okay. And what about lithium? That's often mentioned with diuretics.
Big interaction. Most diuretics, particularly thiazides, tend to increase lithium reabsorption back into the body, likely happening in the proximal tubule alongside sodium.
So lithium levels go up?
Yes, potentially to toxic levels. If a patient on stable lithium therapy needs to start a diuretic, especially a thiazide, their lithium level must be monitored very closely, and the lithium dose often needs to be reduced. Amiloride, as we noted, is different because it blocks lithium entry distally.
Right. Okay, finally, the challenge of diuretic resistance. When a patient is on, say, high-dose furosemide and it just stops working as well, what's going on?
Resistance or refractoriness is common and complex. Several factors can contribute. Obviously, worsening kidney function, low GFR, reduces drug delivery. In severe heart failure, poor gut absorption of oral drugs and reduced renal blood flow play a role. In cirrhosis or nephrotic syndrome, high aldosterone levels contribute, and sometimes the diuretic binds to protein lost in the urine.
But you mentioned something specific that happens with long-term loop diuretic use.
Yes, a fascinating adaptation by the kidney itself. With chronic heavy blockade of sodium reabsorption in the loop of Henle, the downstream segments, particularly the distal tubule, undergo physical changes. They actually hypertrophy.
The cells get bigger.
The cells get bigger and increase their number of sodium transporters. They physically enlarge their capacity to reabsorb sodium, desperately trying to compensate for the massive load being delivered from the blocked loop.
So the kidney literally remodels itself to fight the drug's effect.
Exactly. This distal nephron hypertrophy is a major cause of resistance developing over time in patients on chronic high-dose loop diuretics.
So let's put it together. Imagine a patient, maybe with cirrhosis, who is initially doing okay on furosemide, but now they need higher doses, it's not working well, and they've developed severe hypokalemia, maybe neurological symptoms. What's likely happening, and what's the strategy?
That's a classic picture. You likely have a combination of things. The cirrhosis itself causes secondary hyperaldosteronism, driving potassium loss and some resistance. The high-dose furosemide has probably induced that distal nephron hypertrophy, causing further resistance. The hypokalemia is worsening the situation and causing symptoms.
So what do you do? Just more furosemide won't work.
No. The key is combination therapy targeting both problems. You need to counteract the hypoaldosteronism and the distal hypertrophy. So you would typically add an aldosterone antagonist, like spironolactone, to block the aldosterone effect and conserve potassium.
Okay, that handles the aldosterone part. What about the hypertrophy distal tubule?
You need to block that site too. That's where adding a thiazide diuretic comes in, especially metolazone, given its ability to work in lower GFR and its potent synergistic effect. By blocking sodium reabsorption sequentially, first in the loop with furosemide, then in the now hypertrophy distal tubule with the thiazide metolazone, you can often overcome the resistance and achieve significant diuresis again.
So a loop plus a thiazide plus potentially spironolactone. That sounds like a powerful combination.
Extremely powerful. It's sometimes called sequential nephron blockade, but it requires very, very close monitoring of fluids, electrolytes, and kidney function because you can get massive, rapid fluid shifts and severe electrolyte depletion if you're not careful. It's a specialist strategy.
Wow. We have really journeyed through the intricate pathways of the nephron today. We've mapped the 5 key classes from the high-ceiling loop diuretics like furosemide acting fast at site 2, wasting calcium and eating prostaglandins, to the medium efficacy thiazides at site 3, the antihypertensive workhorses that uniquely save calcium but often fail when kidney function is poor. We covered the specialized, self-limiting case inhibitors like acetazolamide, now used mainly for non-diuretic reasons, and the osmotic agent mannitol, purely for pressure, never chronic edema.
And we detailed the 2 distinct potassium-sparing mechanisms at site V spironolactone, competitively blocking aldosterone's genomic effects, taking days to work, versus amiloride directly plugging the E-NAZ channel for immediate aldosterone-independent effect. Remembering the relative power is useful too. Loops and mannitol are high efficacy, 20 to 25% sodium excretion, thiazides intermediate, around 8%, and the case inhibitors and K-plus sparers are quite mild, only 3 to 5%.
I think the biggest takeaway from this deep dive, for me anyway, is that the diuretic's initial mechanism is really only half the story. True mastery seems to lie not just in knowing where the drug acts site 2, site 3, site V, but in being able to anticipate the body's incredibly powerful, layered, and sometimes self-defeating counterresponses.
That's absolutely it. The RAAS activation, that distal hypertrophy we just discussed, the prostaglandin dependence, these aren't just side effects. They are reflections of the kidney's fundamental physiology trying to maintain balance.
So the real challenge is managing the drug and the body's reaction to it.
Precisely. And what's fascinating here is you can almost see the entire complexity of salt and water balance laid bare in the adverse effects and interactions of these drugs. Every electrolyte disturbance, every resistance mechanism is a direct, predictable consequence of disrupting one part of the system and forcing the rest of the nephron to compensate. So the next step for every learner, for everyone listening, is to realize that when a diuretic seems to fail, it's often not the drug that simply quit. It's usually the kidney's amazing compensatory physiology that won that round. Your job then becomes figuring out the right combination strategy to win the balance back for your patient.